Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical textbook, or I should say Mehlman Medical Internal Medicine PDF, talking again about the musculoskeletal section. Now, we left off that yesterday night, or yesternight you could say, and we were at lower limb high yield points for internal medicine. If my memory serves correctly. Yeah, I think we went over scoliosis and that kind of thing, and we wanted to finish up here. Yes. Okay, so let's get back into it. We're on 316. I believe the chapter ends on 331, if my memory serves correctly. Let's check that out. Yes. Okay. We'll see if we can do this in one go. Lower limb nerve high yield points for internal medicine. Common peroneal fibular nerve. The answer on USMLE if patient loses both eversion and dorsiflexion of the foot. Sensation to upper third of the lateral leg, around and below lateral knee. Splits into superficial and deep peroneal fibular nerves. Superficial peroneal nerve. The answer on USMLE if the patient loses only eversion of the foot, but dorsiflexion stays intact. So again, we have common peroneal that has superficial and deep, but that superficial would only have the eversion loss, but it would have dorsiflexion intact. What about deep peroneal nerve? The answer on USMLE if the patient loses only the dorsiflexion of the foot, but the eversion stays intact. So deep for dorsiflexion, which means that the superficial is the one that's for eversion instead. Loss of the dorsiflexion causes a high steppage gait. Patient has to lift foot high into the air with each step, because again, they can't dorsiflex. Also does sensation to webbing between first and second toes. I've never seen NBME questions care about this sensation detail, but students get fanatical about it as it's supposed to be high yield. Tibial nerve. The answer on USMLE if the patient loses plantar flexion on the foot, can't stand on tippy toes, sensation to bottom of the foot / heel. So remember, tippy toes, tibial nerve. Sciatic nerve. The answer on USMLE if the patient has a motor dysfunction of the tibial and common peroneal nerves at the same time, or has sciatica, shooting pain down the leg, splits into the common peroneal nerve and the tibial nerve. It does not supply sensation to thigh. Sensation encompasses that supplied by the combination of the common peroneal nerve and the tibial nerves. Supplies some motor function to muscles of thigh, but USMLE does not care. Sciatica equals shooting pain from the lower back down the leg, usually as a result of the disc herniation. 2CK forms simply want NSAIDs as treatment. The straight leg raise is classically used in part to diagnose, but I've seen this test show up on NBME material for simple lumbosacral strain. That is to say, the test is non-specific and not reliable. So again, it's not a specific test for sciatic nerve. You might use it, but it's not specific for it. So if you get a result that you think would be conducive to it, it doesn't necessarily guarantee that's the answer. Obturator nerve. The answer on USMLE if the patient has an inability to adduct the hip with loss of sensation to medial thigh. Okay. So obturators for adduction. Thigh adduction, yes. Femoral nerve. The answer on USMLE if the patient cannot extend the knee or has buckling at the knee. Another thing to be aware of that when they say extension at the knee, they don't mean, when we talk about when you flex your elbow or you flex your thigh, for example, you're thinking of a sort of anterior motion, but the knee flexion is actually a backwards motion. The leg actually goes posterior at the knee. And now it makes sense that it's still flexion, but it's just that because of how the knee is oriented, when you flex at the knee, your foot goes back and your lower leg goes back. So bear that in mind. So when they say extension of the knee, they mean making your knee upright. When you're standing up, your knees are extended because they need to be upright for you to stand. You see what I'm saying? So femoral nerve is involved in knee extension, and so there's also a limitation on being able to do that, as well as buckling at the knee. Also does sensation to the anterior thigh plus medial leg, not thigh. Although I haven't seen cessation specifically asked for femoral nerve. So it looks like they're less interested in a lot of this dermatomal sensation stuff. It's not necessarily not going to be on there, but it's not as big of a deal to them as the muscle movement. What about saphenous nerve? The answer on the USMLE, if the patient loses sensation to the medial leg, pure sensory branch of the femoral nerve. Sural nerve. The answer on USMLE, if the patient loses sensation to the lower lateral leg. In contrast, if sensation is lost in the upper lateral leg, that's common peroneal nerve instead. Often confused with saphenous nerve. Good way to remember is sural is lateral. Therefore, saphenous must be the one that's medial. So saphenous medial, sural lateral. Superior gluteal nerve. The answer on USMLE, if a patient has a Trendelenburg gait, opposite side of the pelvis will fall while walking, so the patient will tilt the trunk side of the lesion walking to maintain the level of pelvis. Innervates gluteus medius and minimus. So basically what happens is this. So superior gluteal nerve innervates the gluteus medius. So if you have a deficiency, let's say on the left gluteal nerve, you will have a right hip drop. So your right hip will drop if the left side has a has weakness of the muscle, gluteus medius, which means you have a left-sided superior gluteal nerve issue. So the hip drop is on the opposite side of the actual dysfunction. Inferior gluteal nerve. The answer in USMLE for a patient who cannot squat, stand up from a chair, or go up or down stairs. Innervates the gluteus maximus muscle. So here's the dermatome map. I was talking a little bit about dermatomes yesterday in the previous video for this section, MSK. Now, you can see, V1, V2, V3. That's trigeminal nerve. So trigeminal nerve is cranial nerve 5, which is why it's called V. The other stuff down there, that's cervical, C1, C2, 3, so forth. We also have the T, thoracic, right? You can see that there. We also have the L, lumbar, and then we have the S, sacral. So these are different parts of the spine. Now, bear in mind also that, what's that? It's interesting. C8's like that. I was talking also about the location for where we want to test sensation with the dermatomes. So one of the things you could do, you can't see me do this in person. You just see a little guy on the screen for you. But if you touch the side of your shoulder, sort of the lateral part of your shoulder, that's C5, dermatome center. That's a good place to test for C5. If you test your thumb, that's C6. You test your middle finger, C7. You test your pinky, C8. And in some versions, the side of the medial elbow area, that area that's on the side of the pinky, that's going to be T1. And if you go farther up, closer to the armpit, that's going to be T2. Not in the armpit, but a little bit higher, close to it, proximal to it. There's some variations in how they draw the dermatomes, but just bear that in mind. That's probably going to be a pretty good way to figure it out. Another way to look at it is like this. If you lift up your arm to horizontally, so let's say your arm's to your side, you lift it up horizontally, that's C5. If you flex at the elbow and bring your fist towards you, that flexion there is C6. When you use your triceps to bring it back out, so you extend your arm back out again at the elbow, that's C7. And I forgot how the C8T1 works. I think it's like the fingers going in and out. I think when you open, I forgot how, if it's like opening and closing your fingers and stuff like that, that's like C8T1. I'm not as clean on that one. But just know that if you lift up your arm at the shoulder, that's C5. You flex your wrist, you flex at the elbow, that's C6, and you extend at the wrist, that's C7. But C8T1 is more like a finger thing. C5, C6, C7, C8. Okay. I'm thinking about this let's say, lift up your arm to the horizontal, C5. Flex at the elbow and extend at the wrist, that's C6. Extend at the elbow and flex at the wrist, that's C7. And then I think it's C8T1 for the interosseous sort of muscles. You put your fingers, close and open up your hands, that kind of thing. That's where C8T1 is kind of occurring at, I suppose. Again, that might be an imperfect thing. There might be some critique of that, certainly with C8T1 stuff. I would look into that if I were you, because they do ask questions occasionally. This is more of like an OPP thing, But if you have a complex exam, you might have to take that into consideration. Let me go look that up right now. How do I test for C8? How do you test for C8 nerve? It says here, you test for C8 nerve root. A healthcare provider will evaluate motor strength. No kidding. Finger grip, thumb extension. So they say finger grip, okay, thumb extension. So okay, so it says here C8 flex their distal interphalangeal or DIP joints. So that's like the finger, that's the actual trying to flex your fingers. And then T1, test for finger abduction, adduction. Okay, so that's the best way to phrase it. So again, let's round it up again. So C5, bring your arm to horizontal. C6, flex your elbow but extend your wrist. C7, extend your elbow but flex your wrist. I think that's how it goes. For C8, you open up your hand. So let's say it was a fist before, now you open up your hand. And then T1, you kind of fan out and fan in your fingers, bringing them up, abducting them, adducting them, you know. So again, C8 would be like flexing your actual fingers, like almost like you're making a little claw or something like that. I'm not perfect with that. If you want to know more about that, I would look into it if you really wanted to. Probably isn't that big of a deal, to be honest with you, but I just wanted to give you my 2 cents. Take it with a grain of salt. Lower limb reflexes / radiculopathies. So L4 radiculopathy, the answer in USMLE if the patient loses their knee patellar reflex plus has weakened knee extension. The pain / paresthesias and numbness in L4 distribution, anterior thigh plus medial leg. Disc herniation of L3, L4. Yep, it's a lower level. Just remember that the L4 is the one that the knee reflex is messed up. We're keeping it PC. Well, we're keeping it PG. We're keeping it PC and PG. Well, mainly PG. mainly more so that. L5 radiculopathy. L5 radiculopathy. The answer on USMLE if the patient loses dorsiflexion. The pain / paresthesias and numbness in the L5 distribution, lateral and anterior leg. Disc herniation of L4, L5. Yeah, so just bear in mind that L4 I'll finish this up and I'll let you know. So S1, next one, the answer in USMLE if the patient loses their Achilles reflex, ankle reflex, has weakened plantar flexion. So pain / paresthesias and numbness in S1 distribution, sole of the foot and lower leg, disc herniation of L5, S1. Just remember that S1 is the one where the ankle reflex is messed up. SALT, S1, Achilles, lateral leg dermatome, tibial motor issue, plantar flexion. Now, what I wanted to say is that you have a knee reflex when you tap on the knee, right? And you also have an Achilles reflex when you tap on the Achilles tendon in the heel. The knee one is done by L4, while the Achilles is done by S1. L5 does not have a reflex associated with it to test for. And so if you have a situation where one of these issues is messed up, but you don't feel a reflex, it's probably L5. If you're debating between L4, L5, S1, think about, is there a reflex deficiency? Because if there is not one, probably it's L5. If you do have one, well, is it a knee one or is it an Achilles tendon, right? Think about it like that. Furthermore, again, it's saying here that for L4, you test for L4 by extending your knee, you test for L5 by dorsiflexing your foot, and you test your S1 by plantar flexing your foot. So imagine you can do this now. Extend your leg, that's L4. Extend your leg at the knee, that's L4. Dorsiflex your foot, bring your foot up, that's L5. Plantar flex your foot down, that's S1. Lower limb differential diagnosis for internal medicine. Trochanteric bursitis. Vignette will be a lateral hip pain that is worsened with palpation plus lying on one side in bed. The treatment should be NSAIDs. Septic bursitis. USMLE will give inflammation of the knee joint that sounds like septic arthritis, but they will say there's no joint effusion. This is how it presents in a 2CK NBME vignette, where the student constantly asks, why not septic arthritis? And they say in the vignette, there's no joint effusion. So it says, USMLE will give you inflammation in the knee that sounds like septic arthritis, but they'll say there's no joint effusion. This is how you know 2CK vignette. They're asked, why not joint septic arthritis? And they say in the vignette, there's no joint effusion. So you need to apparently have, for septic arthritis, you need to have joint effusion. For the arthritic septic arthritis, you need joint effusion. But septic bursitis will not have that effusion. How do you treat septic bursitis? Antibiotics. Prepatellar bursitis, aka housemaid's knee, presents as an anterior knee pain in people who are frequently on their knees, painters and plumbers, etc. Patellar tendonitis, or jumper's knee, inflammation of the joint of the patellar tendon. The answer on USMLE, if they describe an anterior knee pain that initially occurs only after finishing sports, that is to say, basketball game, then progresses to more chronic pain, treatment on NBME would be quadriceps strengthening exercises. What about patellofemoral instability? Presentation is annoyingly similar to patellar tendonitis, but do not confuse. Patellofemoral instability is misalignment of the patella at the trochlear groove of the femur. The question can mention crepitus. Shows up on 2CK NBME form, 2CK form as a teenage girl who has knee pain, worse after jumping or running, plus has crepitus. The answer should be patellofemoral instability. Patellotendinitis / jumper's knee is not listed as an answer. Patellofemoral pain syndrome, aka chondromalacia patellae. Name implies a softening of cartilage in the knee. The answer on NBME, if they say pain that worsens when sitting for long periods of time or when going up or downstairs. The classic in obesity for those who squat heavy weight, knees think you're obese, treatment would be quadriceps strengthening exercise. So again, that's going to be for either a classic in obesity or people who squat heavy weight. This is the ACL stuff. So anterior cruciate ligament injury. ACL is the answer of positive anterior drawer test or Lockman test, the excessive anterior displacement of tibia relative to the femur. Because basically what happens is that this ligament is trying to prevent the anterior displacement, and so if you forcefully try to anteriorly displace it, and it's positive, it displaces in a way that's really unnatural or abnormal, that means you have an injury of the ACL, because it's supposed to keep that from happening. Classically injured when the knee is hyperextended or with rotational force on a fixed planted knee. Well, what about PCL, the posterior cruciate ligament? PCL is the answer positive for posterior drawer test, excessive posterior displacement of the tibia relative to the femur. Again, PCL is doing the opposite. It prevents posterior displacement, so if you can posteriorly displace pretty handedly, a lot more than you ought to, that probably means PCL is injured. What about lateral collateral ligament? So LCL is the answer. The varus test is excessive lateral motion of the knee compared to the unaffected side. So you think about what coxavarus is and coxavalgus is. I might not explain it to you right now, but look up coxavarus, coxavalgus. That's C-O-X-A, varus, V-A-R-U-S, and then valgus, V-A-L-G-U-S. There's also something called because there's the os coxa, which is the hip bone, the bone of the hip, the innominate. There's also this thing called the genu varus and genu valgus. Genu varus, G-E-N-U, and then varus and valgus. That's for the knee. So when they say varus test, I might have misspoken before, but when they speak about varus test for the knee, they mean genu varus. So when you bring the knee, let me look this up right now and make sure they're not misspeaking. But I think when you bring the knee joint laterally outward, that was what they're talking about genu varus in that case. Genu varus and valgus. Oops, there we go. So let's look at this. Genu varum is, when you bring the knee joint, think about the knee joint. You're standing upright or you're laying down. If you bring the knee joints outward, that's called genu varum. When you bring the knee joints inward, like the person's knock-kneed, like a kawaii, shy anime girl who's knock-kneed, that's called genu valgum. Okay. Makes sense? So because lateral collateral ligaments trying to prevent this sort of excess lateral motion, if you can do excess lateral motion, i.e. genu varum, at that knee joint, that means you have a lateral collateral ligament injury. It seems that you do. So varus test, hand placed on the medial knee and pushed outward, plus other hand placed on the lateral ankle and pushing inward. Also bear in mind, I believe genu varus, which is what we're talking about right now, knock-kneedness. Or that's genu valgum, sorry. Genu varus, where we're putting the knee outward, that's like almost like a bow-legged appearance. I believe genu varus is paired with coxa valgum, while conversely, genu valgum, where you're knock-kneed, again, that's like the little kawaii anime girl, whatever, where she's knock-kneed, that's paired with coxa vera. So coxa vera with genu valgum, and then coxa valgum with genu vera. So it's kind of like flipped, that kind of thing. But just look it up if I were you. Again, you don't even have to take my word for it. Just look it up. Just see what knock-kneed versus bow-legged looks like. Anyway, next one, medial collateral ligament injury. The MCL is the answer to the valgus test induces excessive medial motion of the knee compared to the unaffected side. So again, this case it's genu valgus. This is an actual knock-knee presentation as we are talking about before, where the knees are going towards the center. If you can do that excessively, that's an MCL issue. Valgus test, hand placed on the lateral knee and pushing inward, while the other hand is placed on the medial ankle and pulling outward. Okay. Again, just look it up, just so you can get a good visual depiction of that. Lateral meniscal tear. Lateral knee pain where the patient experiences a locking or catching of the knee in partial flexion. Okay. Diagnosed with McMurray test, internal rotation of the leg with concurrent knee extension causes lateral knee pain, catching. Medial meniscal tear. Medial knee pain where the patient experiences locking or catching of the knee in the partial flexion. Diagnosed with McMurray test, external rotation of the knee with concurrent extension causes the knee pain/catching. So in these cases of meniscal tears, it's not so much that there's a displacement issue, it's that pain is induced when you put them in a certain presentation. So lateral meniscal, if you do internal rotation with concurrent extension, while medial meniscal, if you do external rotation with concurrent flexion, or with concurrent extension, sorry. So both do extension, but you have to the question is, you're doing internal for lateral, or you're doing external rotation for medial. What is the unhappy triad? Well, it refers to the trio injury of the ACL, MCL, and either the medial or lateral meniscus. Usually it's the medial meniscus. If you have an MCL issue, it's probably the medial meniscus. It could be lateral meniscus, I guess, but I've heard it more so in the past as being the medial meniscus. I always remember it as MMA. Medial meniscus, medial collateral ligament, and anterior cruciate ligament. So you can think about MMA in that way. Students are sometimes fanatical about this triad as though it has yieldness. USMLE does not care. I cannot recall a single MBME question where this has ever been assessed. This diagnosis primarily resides within the domain of QBank, not the MBME. However, I will say, though, if you were taking Comlex, it is probably more likely to pop up compared to the step 2. Pes anserine bursitis. The answer on USMLE, the patient has infromedial knee pain. Iliotibial band syndrome. The answer on USMLE, they say the lateral knee pain, usually in a runner, the iliotibial band runs from the hip to the knee. Pain may occur anywhere along the hip or lateral thigh or lateral knee, but is worst in the latter case with the lateral knee. Treatment would be a conservative with physiotherapy, NSAIDs for pain. Okay, what about Osgood-Schlatter disease? So Osgood-Schlatter disease, Buzzy vignette is knee pain is fast-growing teenage male who plays soccer. Don't pigeonhole things, but that's classic vignette. So yeah, I mean, they might show that to you and say, oh, clearly it's Osgood-Schlatter, but maybe that's the answer and it doesn't have the exact presentation. Just be aware of that. Not true for any of these things as far as I'm aware. They might have a classical presentation, you start thinking, oh, of course it's this thing here, but maybe they don't give you the classic presentation, and so just be aware that things might be a little bit more complicated. Anyway, so inflammation, so Osgood-Schlatter disease, inflammation of the patellar ligament, at the tibial tuberosity. Mechanism is repeated stress of the growth plate on the superior tibia. Plantar fasciitis. The answer on USMLE, if they give several heel pain, is worse when first getting out of bed in the morning. Morton neuroma. The answer on USMLE, if the patient has a pain plus abnormal growth occurring between the second and third metatarsals, usually worsened with high heel shoes. Benign growth/tumor of the intertarsal nerve, cause is idiopathic. First step in diagnosis is the X-ray to rule out arthritis plus fractures. Ultrasound is then done to confirm the diagnosis, which will show thickening of the intertarsal nerve. Treatment would be orthotics, comfortable shoes, plus steroid injection for more neuroma. So it's worse with high heel shoes. You treat it with comfortable shoes and steroid injection. Neurogenic joint. As discussed already, aka Charcot joint, where the patient injures the joint due to the lack of joint sensation from the peripheral neuropathy. Usually seen in diabetes, but can also be seen in neurosyphilis. The answer on USMLE, when they say diabetic patient has a disorganization of the tarso-metatarsal joints on foot X-ray, would be neurogenic joint. Okay, so where are we now? We're 27 minutes in. We're on 319. We made some progress. Where did we start off on again? We made we got through a few pages. But I'll take a break. If you were watching the video as a recording, I would probably skip ahead. So let's do that right now. Okay. Well, I think we're back. The royal we're back, right? But seriously, though, let us go back into it. High-yield fractures point for surgery. So high-yield fracture points for surgery. Okay. Spinal fracture, pathognomonic for child abuse. Okay. Sorry, spiral fracture, pathognomonic for child abuse, caused by rotation/twisting force applied to a limb. USMLE does not expect you to diagnose based on imaging. Simple fracture, aka closed fracture, that is to say the skin is not broken and the underlying bone does not pierce the skin. Compound fracture, aka open fracture, that is to say the skin is broken and the underlying bone pierces the skin. That's not fun. Comminuted fracture, fracture where the bone is broken into at least two pieces. Green stick fracture, bone bends and cracks instead of breaking completely into two pieces, more common in peds than adults. Why is it called that? Well, let's say we have a tree. And let's say the tree's pretty old. You know, if you let's say you're trying to break a branch from a tree, it's really old, this is an old branch, it'll just crack and break, right? Obviously. But if it's let's say you have a tree, it could be a young tree, it could be like a sapling, maybe it's a tree that's older, but this is a new branch. You're trying to break it, it doesn't necessarily crack, it might just bend. And maybe it cracks or breaks a little bit partially, but it doesn't really want to crack like you would with a dry old stick. It wants to kind of like bend and be flexible. Apparently, the same principle applies to children's bones as well. So if you try to if you're in a situation where a child's bone is put in a position where it would potentially break, it might just kind of partially break, but also not completely break like it would with an adult. So it says here, children's bones are more flexible than adult bones because they have higher collagen content and lower mineral content, allowing them to bend more. When a force that would cause by the way, that's why it's called green stick fracture, like the sort of the green young wood of a tree that's a new branch that might not necessarily crack, but might just kind of like partially bend and break in that way. It's not a satisfying crack of an old stick. It's the bending of a young green branch. So anyway, elevated collagen content and lower mineral content, allowing them to bend more. When a force that would cause a complete fracture in an adult bone is applied to a child's bone, it might only cause a green stick fracture, which is an incomplete fracture with the bone bending and breaking only on one side, resembling a green branch of a tree that bends or splinters on one side without breaking completely. Exactly. Linear skull fracture. Most common type of skull fracture where there is a break in the skull but the bone has not moved. USMLE wants you to know that this is basically classically associated with the epidural hematoma, which is S on 2CK CMS form. So epidural hematoma for linear skull fracture. Base of skull fracture. Presents with tetrad of battle sign, bruising over mastoid process, raccoon eyes, bruising around the eyes, rhinorrhea, and otorrhea. What about metatarsal stress fracture? Well, the answer on USMLE for pain in the metatarsal area of the foot in long-distance runners with low BMI. Rather than asking the diagnosis directly, USMLE will only give a vignette where a female long-distance runner with a low BMI already has a metatarsal stress fracture. And then they'll ask you, she's at greatest risk for developing, what is it? Osteoporosis. Clavicular fracture. So clavicular fracture occurs with fall on outstretched hand, FOSH, I guess, or occasional as a result of handlebar injury, impaction with force transferred up to clavicle. Most common site of break is the middle third of the clavicle. Treatment should be figure of 8 sling. Scaphoid fracture, as discussed earlier, will present as pain over the anatomic snuff box in patient with FOSH. X-ray will usually be negative acutely. Must do thumb spica test. thumb spica cast to prevent avascular necrosis of scaphoid, followed by repeat X-ray in 2 to 3 weeks. Okay. Lunate fracture. Lunate fracture, the answer in USMLE if FOSH with pain in central palm plus no pain over anatomic snuff box. So if you have pain in the central palm but there's no anatomic snuff box pain, it might be lunate fracture. Assuming that you also still have the fall and outstretched hand issue. What about hook of hamate fracture? Remember hook of hamate? We were talking about Guyon's canal. Cause of distal ulnar nerve injury, Guyon canal syndrome, often from handlebar injury / impaction. Surgical neck of humerus fracture. So we're kind of replaying a little stuff we did yesterday a little bit with this kind of stuff. Surgical neck of humerus fracture causes axillary nerve injury, loss of deltoid function plus sensation over the deltoid. Mid-shaft fracture of the humerus causes radial nerve injury, wrist drop plus pronated arm. Supracondylar fracture of the humerus, also called the distal shaft fracture. This causes a median nerve injury, which leads to motor / sensory dysfunction of the forearm muscles, first 3 fingers, and the thenar region. So because it's a medial nerve injury, that has going to have some overlap with what carpal tunnel kind of looks like, because it's affecting the same nerve, but at a different location, in all fairness. So it's not going to be the same presentation, but it's going to have some overlap in terms of how it presents. Vertebral compression fracture, synonymous with the osteoporosis and USMLE, that is to say postmenopausal corticosteroid use Cushing syndrome, will often give a point tenderness over a vertebra. Pseudofracture, band of low-density bone that looks like fracture on X-ray but not actual fracture, synonymous with vitamin D deficiency, osteomalacia / rickets on USMLE. Can be seen in renal failure since the 125D3 is low. Osteomalacia due to renal failure is called renal osteodystrophy. Orbital floor fracture. Orbital floor fracture. USMLE wants to know this can cause entrapment of inferior rectus and inferior oblique muscles. Vignette will say guy got hit in the eye by a baseball, plus has impaired upward gaze. I talk about extraocular muscles and lesions in my neuroanatomy document, but this one notable point you should be aware of here. Let me go back at that a little bit. So it says orbital floor fracture, inferior rectus, inferior oblique muscle entrapment. Okay. Tell us about the Ottawa criteria, Mr. Dmitry. Well, let's see. Ottawa criteria. Used to assess probability of ankle fracture and tells us whether we need to order an X-ray or versus supportive care. That is to say, let's say E.g. rest, ice compression, elevation. That's the supportive care. Before development of this criteria, X-rays for the ankle used to be ordered frivolously, with most showing no fracture. Only order an X-ray for the ankle if pain in the malleolar zone and any of the following: tenderness posterior to the lateral or medial malleolus, or tenderness on the tip of the lateral or medial malleolus, or patient cannot bear weight when walking 4 steps. So if they cannot bear weight when walking 4 steps, or they have posterior to lateral or tip of the lateral to medial. Sorry, let me read it again. So if you have medial malleolus pain, or you have posterior to the lateral or tip of the lateral pain. So basically, I guess it's referring to also the malleoli in that case as well. So basically, if you have medial malleolus pain, lateral malleolus pain, where you're walking 4 steps and you cannot bear weight, or you have pain if you have one of those things, plus you have like malleolar pain in the malleolar zone, then you will have an indication that you should go and have X-ray for potential fracture. We don't say anymore, we're just going to give you an X-ray just because maybe it's under those circumstances, because I felt I was being too frivolous before in the past. Let me look up malleolar zone right now to make sure I'm not saying anything incorrectly. the malleolar zone, malleolar region, the medial malleolus formed by the tibia is found on the inside of the ankle. The posterior medial malleolus, also formed by the tibia, is found on the back of the ankle. The lateral malleolus formed by the fibula is found on the outer aspect of the ankle. So malleolar zone, malleolar region is just like the area where the malleoli are hanging out at. So what they're saying is, if you have a malleolar pain in the malleolar zone, and you have tenderness in the posterior to the lateral posterior, or the tip of the lateral or medial malleoli, so pretty broad, as long as you have some sort of malleoli pain. Is it medial lateral, is it tip, or is it posterior, but you can't, and also, or if you can't bear weight, probably should go get an x-ray. The answer might seem nitpicky and pedantic, but this is high yield for 2CK. Examples: 25M plus twisted ankle, who's 25-year-old male, I would assume, but 25M plus twisted ankle yesterday, plus moderate edema for lateral side of the ankle with ecchymoses, plus tenderness to palpation, lateral and anterior to lateral malleolus, plus patient can bear weight, can weight bear, whatever. Question asks, in addition to 2-day ice pack application, what is the next step? The answer would be on the shelf, use a soft protective brace and early range of motion exercises. The wrong answer would be x-ray the ankle to rule out fracture. Again, you want to have very specific criteria for that, okay? What it says here, tenderness to palpation lateral and anterior to the lateral malleolus, plus patient can weight bear. Well, is it tenderness to palpation, lateral and anterior? Lateral, what does it say? Lateral, anterior to lateral malleolus. So lateral malleolus. So it says anterior, so it has to be either the posterior part or the tip. So you have pain in the tip, go for it. Go check it out. If it's in the posterior part of the malleolus, go for it. Check it out. But if it's the anterior part, apparently not. Not sufficient. Okay, next one. 40M plus, I guess I assume that's a 40-year-old male, plus playing basketball, rolls ankle and pain anterior to lateral malleolus, plus swelling of ankle pain, no pain posterior to lateral malleolus. It says no pain posterior, right? No pain posterior, doesn't indicate any pain in the tip. It indicates only anterior pain. Can bear weight. Question wants next best step. The management answer should be rest, ice, compression, elevation. Wrong answer is x-ray. The patient doesn't fully fulfill the audible criteria. He has pain in the malleolar zone, but does not have the pain in the posterior to the malleolus or on the tip of the malleolus, and he can bear weight. If he had it in the posterior tip part, that would be appropriate, but it's the anterior part, so no. So I'm glad he's explaining this stuff a little bit more detailed because I didn't know exactly where the cutoff points would be. 26-year-old female went running and rolled her ankle plus pain in lateral ankle plus tenderness posterior to malleolus. It can bear weight. So she said here, pain in lateral ankle, tenderness posterior to malleolus, posterior, so that means it qualifies, right, in theory. Answer should be x-ray of the ankle. Patient fulfills audible criteria for the x-ray. She has pain in the malleolar region plus tenderness in the posterior to the malleolus, although she can bear weight. The former two findings satisfy the audible criteria. Okay, I might take another break. Again, if you're watching recordings, just skip ahead. high-yield hip disorders for surgery. Oh yeah, by the way, I'm back. Okay, anyways. High-yield pediatric hip disorders for surgery. Primary hip dysplasia, aka development dysplasia of the hip. Mechanism is poorly developed acetabulum. Initial diagnosis is with Ortolani and Barlow maneuvers, where a clicking and clunking is elicited on physical exam. So, if I were you, and you don't know what those are, go out there and just look it up. Look it up. They say Ortolani and Barlow. What you really have to do is do Barlow before Ortolani. So it's B-O, Barlow, Ortolani. You do Barlow to displace the hip. If it can displace it, that means there's an issue. And you use Ortolani to go basically put it back into place. It's kind of crazy they do these infants, but it's something to test for, you know. After the O&A maneuvers, next best step is the ortho referral. Sounds wrong, but if it's listed, it's the answer before going to imaging. Definitely diagnosed with hip ultrasound if it's less than 6 months of age. Hip x-ray if greater than 6 months of age. Treatment would be abduction harness, aka Pavlik harness, which positions the child's legs in a frog leg appearing manner. Legg-Calvé-Perthes disease. One of the situations where they really couldn't decide who gets to put the name on the condition, on the discovery. So they just put 3 names together. Why not? Legg-Calvé-Perthes disease, aka idiopathic avascular necrosis of the femoral head. And the etiology for the avascular necrosis is known: Gaucher, sickle cell, corticosteroids. Then the diagnosis is just avascular necrosis, not Legg-Calvé-Perthes disease. Vignette will be a child 5 to 8 years old with hip pain. First step in diagnosis is X-ray, which will show a contracted or flattened femoral head. The word contracted is high yield and synonymous with avascular necrosis. If X-ray is negative, diagnosed with bone scan or MRI on 2CK form, the treatment should be hip replacement. Because again, it's necrotic, right? X-ray shows a flattened/contracted femoral head compared with the normal side that looks rounder. And you can see the picture right there. Here we have another depiction. On MRI, the right femoral head, left side of the image, appears hypo intense, more black. The necrotic/lack of bone in the black superior portion of the femoral head means that the remaining white part of the femoral head is flattened or contracted. The left femoral head, right side of the image, shows a small area of necrosis as well, black medial portion. So this person has a little bit of necrosis on both sides. Slipped capital femoral epiphysis, SCFE. Classic vignette is a 10 to 13-year-old pre-adolescent overweight boy with a painful limp. NBME will write an answer/mechanism as displacement of the epiphysis of the femoral head. Resources tend to emphasize obesity as a main risk factor, but maybe only half of NBME questions for SCFE give the patient as overweight. This causes problems for students where they rely on seeing high BMI to think for SCFE, when you really don't necessarily need it in the question for it to be the case. This has led to me to conclude that the age matters the most, since they'll always give a kid who's about 10 to 13-ish. If they give you a kid who's younger, think LCP instead, which is like Legg-Calvé-Perthes disease. So if it's younger than 10, start thinking Perthes. If it's 10 to 13, think maybe it's SCFE, subcapital femoral epiphysis. 2CK NBME question gives a 13-year-old male with a painful gait plus no mention of weight. The answer is probably SCFE. Another 2CK question outright says BMI is 20 in a 13-year-old who's 6 feet tall, and the answer is SCFE. X-ray shows an ice cream falling off the cone. Yeah, if I were you, look it up yourself. If you don't, I don't know if they have a picture here. Yeah, they do. Yeah, doesn't it look like it right here? X-ray shows the ice cream slipping off the cone. The literal like cap of the femur is like falling off the bone, like as if it was the ice cream falling off the cone. Offline 2CK gives a question where they say that the X-ray in the five-year-old shows a contracted capital femoral epiphysis. The answer is Legg-Calvé-Perthes disease. Am I saying that right? It's so funny. The name is Legg-Calvé-Perthes. So the other two names are kind of like whatever. Perthes. I've heard it was Perthes disease. Just as a little bit of way to remember it, but. So anyway, if it's a 5-year-old who has contracted a capital femoral epiphysis, start thinking Legg-Calvé-Perthes disease, not SCFE. Again, it's age dependent. As I said before, contracted is high yield for LCP. In this case, though, the younger age plus the word contracted is win over words. Femoral capital epiphysis treatment would be surgical pinning. So if you have actual SCFE, do surgical pinning. It wants to slip off, pin it down surgically. Other peds bone issues for internal medicine. Rickets, vitamin D deficiency in children, osteomalacia, vitamin D deficiency in adults. Rickets, you have craniotube, soft skull, rachitic rosary, bone knobs as costochondral junctions, genuvarum, bowing of the tibias. So you're bow-legged, right? So there's remember that's valgum, I believe it is. Yeah, genuvalgum. While for the other one we were talking about before, that's genuvarum. Oh no, I mixed it up. Genuvarum is when you're bow-legged. Genuvalgum is when you're knock-kneed. So this person who has a rickets, for example, has genuvarum, and so they have bowing of the leg of the tibias, bowing of the legs, where you have this sort of knees going outward and lateral. Activated vitamin D 125 is necessary to convert the unmineralized osteoid into mineralized hydroxyapatite, therefore hardening of bones. In both rickets and osteomalacia, patients will have an increased unmineralized osteoid or deficient mineralization of osteoid. Important cause of vitamin D deficiency in USMLE is impaired classical intestinal malabsorption, that is to say, let's say cystic fibrosis or Crohn's disease, where they have malabsorption, basically vitamin D. For cystic fibrosis, the answer can be written as exocrine pancreas insufficiency, because that's the actual cause of how CF causes this sort of issue. Because what happens is in cystic fibrosis, you have an exocrine pancreas insufficiency. It's not really the main issue technically when we think of CF. We think about what's going on with the lungs, but it does also cause this issue where you can't properly, your pancreas begins to have dysfunction, right? And so you can't expel these pancreatic enzymes to digest fat. And if you can't digest fat, that means you can't really absorb the fat, nor can you absorb the vitamins that are associated with fat absorption. So that would be A, D, E, and K. You need to absorb fat in order to absorb those vitamins, fat-soluble vitamins. And so if you can't do that, then you can't absorb vitamin D, because that's one of the 4 vitamins you associate with it, right? Pseudofracture on X-ray is buzzy finding on osteomalacia/rickets. Patients have a decrease in calcium, decrease in phosphate, and an increase in PTH, parathyroid hormone, due to the decrease in negative feedback at the parathyroid glands. Basically, the body is realizing, oh wow, something's going wrong, we need to up the ante, and so they increase the parathyroid hormone to kind of counteract it, even if it's not going to be necessarily effective at doing its job in counteracting this problem. What about tibia vera? Tibia vera, aka Blount disease. Bowing of the tibias after the age of 2 years in a patient whom rickets has been ruled out. Can be unilateral or bilateral. Bowing of one or more tibias is sometimes normal until the age of 2 years. Treatment would be surgery, osteotomy. Osteopetrosis. Keep that word in mind. Petrosis, Petrum, Petra, Peter, right? Why is he called Peter? Because he is the rock, right? Why is it called osteopetrosis? Because your bone turns to stone. Osteoclast dysfunction resulting in recurrent fractures in children due to the bone density being too high. Sounds weird, but bone strength is based on balanced internal architecture of canals and networks, not just density alone. High-yield differential diagnosis against osteogenesis imperfecta and child abuse. Osteoclast dysfunction is due to deficiency of carbonic anhydrase, too. This enzyme inside osteoclast normally allows osteoclast to form protons to reabsorb bone. Again, your bones get really thick. Your bone turns to stone. Petrosis, Peter. Peter is the rock of the church, right? He's the rock the church is going to be founded on. He's the rock. Petrosis. The bone, osteo, becomes like a stone, petrosis. It's very dense, so dense in fact it actually undermines its function essentially. Right, and then I think it has an elevated risk for fractures resulting in recurrent fractures due to bone density being too high. Yeah, exactly. So it's kind of counterintuitive. You think, well, why would it break so often? It's like, well, because it's not supposed to be that dense, basically. For lack of a better description I can give you. Growing pains. No, this is not a joke. This is an answer straight up on the 2CK NBME form. Vignette is a healthy child, 3 to 12 years, who awakens from sleep with throbbing pain in the legs. No treatment is necessary. You just need to know that diagnosis exists and is not a troll. So yeah, you can actually have growing pains. So you could straight up just say, he'll be fine. And that could be the answer. Talipes equinovarus. So Talipes equinovarus, aka clubfoot, as you can see in the little depiction right there. USMLE just wants you to know that this is treated initially with a serial casting, usually idiopathic, can be seen in Potter sequence. Not the same as rocker bottom foot, aka congenital vertical talus, seen in Edwards syndrome. So it's not the same as rocker bottom foot, which is different. That's different. Okay. But you treat it initially with serial casting. And arthrogryposis. Arthrogryposis. I'm wondering what is this referring to? You just need to know that this fancy name for a child born with multiple joint contractures, if they give you a child with not just a club foot, but also knee and or elbow contractures, the answer is arthrogryposis. Now, I don't know. My suspicion when they say gryposis is that it refers to a grip, which is like a my brain is setting out the word griffin because a griffin is also called a grip, which is spelled including with that spelling too, GRYP. So I don't know what the actual etymology of that is, but I'm curious. I want to know what it is. I can't say that's for sure what the etymology is, but I'm curious. I don't know. Arthrogryposis. Etymology. Oh, wow. It actually kind of... Okay, so they say here, arthrogryposis translates to curving of joints. Okay. It derives from the Greek word arthron, meaning joint, and gryposis, meaning hooking or curving, which stems from grypos, meaning hooked or crooked. Okay, but what is the etymology of griffin? So the word griffin comes from the ancient Greek word grips, which means meant a hooked nosed or mythical beast or dragon. So basically, they do have a common etymology. That is correct. I don't suspect they meant griffin-handed. They probably just meant hooked, I'd assume. But basically, the Greek word grips refers to a hook. Something that's hook, like a hook or something, like a hook-nosed creature, like a griffin, which describes a sharp hooked beak at the eagle's head structure. So it refers to the hook beak, and gryposis in this context refers to a hooked or crooked presentation for what? Well, it's arthro, referring to a joint. So we're talking about a hooking or curving of the joint. So there is a common etymology between the two. So it refers to not just a club foot. If you're given trouble with not just a club foot, but also knee or elbow contractures, etc., the answer is arthrogryposis. They have multiple joint contractures. See, apparently I'm on my etymology A game for today so far, you know. Anyway. I'm going to take another brief, I won't say brief, a break. I will be back with you soon enough, I suppose. Okay, we are back. 325. Page 325, we're trying to wrap up at 331, so it's not that bad so far. We're over an hour in. I think it says 1 hour, 6 minutes, and so on and so forth seconds. So let us continue. Paget disease. So remember French, Paget. Paget disease, idiopathic disorder of increased bone turnover. Bone is described as having a mixed osteoblastic and osteoclastic phases, where the bone appears heterogeneous on X-ray. Basically what's happening is that the bone has a very high turnover because it's breaking it down very, very quickly. And the body's like, oh no, that's not good. We have to go repair all the bone, and so it repairs all this bone quickly as well. And basically it's doing a sort of not very good job. You know, if you've ever been in a situation where you have to do something like, let's say, for example, we're going to give you your, high school, whatever. You have to do a big project. And then on the last day before it's due, your essay, whatever, your dog eats your homework or, whatever, right? And now you have to go, I have to do it all over again. And you have 6 hours to submit it or something like that. Or maybe it's due next period, right? Whatever. And now you're spending all your time trying to get this whole assignment you should have been doing for like a month in 6 hours or whatever. That's kind of like what Paget disease does. It's destroying the bone constantly at a very, very quick rate, and your body's like, oh no, that's not good, and tries to repair it as quickly as possible. And the problem is that this process is not doing a very good job at actually fixing the bone appropriately. And so as a consequence, you have basically heterogeneous, subpar, substandard bone. Buzzy Vignette is a male over the age of 50 whose hat doesn't fit him anymore. He has tinnitus, narrowing of the acoustic foramina. 19 out of 20 questions will give an isolated increase in serum ALP. You need to know that the calcium, phosphate, and PTH are all normal in Paget disease. That's crazy. There is one question on 2CKCMS form where the ALP is given as not elevated, but it's a one-off question and rare. But you will see an elevated serum ALP. High output cardiac failure can occur due to intraosseous AV fistula, where the patient has an S3 heart sound with high rather than low ejection fraction. So high ejection fraction, S3 heart sound. S3 heart sound with a high ejection fraction. Osteoporosis. Bone density 2.5 standard deviations below mean compared to the young adult woman. Osteopenia is 1.5 to 2.5 standard deviations below mean. Bone densitometry done at age 65. If the question forces you to choose between a female gender and age as most important risk factor, choose gender. If a question gives you a female and it forces you to choose between family history and age, choose family history. Males are unlikely to develop osteoporosis even with family history of females with the disorder. If the question gives you two women without family history and asks what is the most protective against osteoporosis, the answer is ethnicity. Black race is protective against osteoporosis. I wonder what I actually don't know what mechanism would cause that. I'm interested. Maybe it's like a different hormone profile. Oh, you know what? Here's my intuition. It might be that black women have... hormone profile is probably a pretty likely answer, just up front, I'll tell you right now. Maybe there's a difference in average hormonal profile. But it might be that black women have more androgenic hormones, like testosterone and other kinds of androgenic hormones. And so maybe they have a more protective effect in the same way that men have a higher protective effect against it compared to women. I don't know. That's just off the top of my head. Do not take that as gospel truth. It is just my immediate intuition. It is also, this is an aside, it is interesting though that a lot of times in medicine, whenever there's an inequality in medical treatment, if it's thing that in theory benefit is to the negative effect of black people, which is the most common, you can say, whatever. There's a higher infant mortality rate for black women giving birth to black infants. Blacks have a lower life expectancy, etc. They always say, they talk about a medical, the institutional racism in medicine, systematic racism against black Americans in America, and in the healthcare field, and more needs to be done to protect this kind of stuff. But they never really go, and I've talked about this before, they never really ask, okay, so what's the infant mortality for, Asians? It's lower than white people? Okay. What about Hispanics? Oh, it's slightly higher than white people, but it's basically very similar. All the Asians, non-Hispanic whites, and also Hispanics all have basically very, very similar infant mortality rates, and then blacks stick out like a sore thumb. Similarly, life expectancy for Asians is higher than whites. Surprisingly, Hispanics, despite having a lower income than whites on average, actually have a higher life expectancy than whites on average, which is interesting. That's probably a cultural thing, not genetic, because of the fact that more white Hispanics actually live longer. So it's probably just a cultural thing of what Hispanics do. It might be a cultural thing of what people from Southern Europe do. They're just more chill about everything. They're not so, they're not so neurotic and high-strung, perhaps. I don't know. And then conversely, blacks have lower life expectancy than these other three races of people. And the intuition is that we're going to say this is the white man's fault, et cetera, et cetera, et cetera. But they never really apply this to... They never seem to have an actual, Weltanschauung, a real worldview to explain why these equalities present themselves the way they do. And to be fair, I can't say that I have a completely comprehensive way to explain this either, but I suspect a combination of environmental and genetic factors, of course, including hormone profiles, the dietary habits of people and their lifestyle choices, which are, or let's be honest, is partly really their own autonomous decisions on some level, along with an actual genetic predisposition to engaging in impulsive behavior. So if, for example, if blacks have more impulsivity compared to other groups of people, and they engage in worse habits in terms of how they eat and how they conduct themselves, etc., is it really everybody else's fault that they wind up having worse health outcomes? I mean, that's kind of a hard sell to give to people. But that doesn't sound as and they say, oh, well, food deserts. I mean, people choose what they buy to eat. So I think a lot of that stuff, this is an example, though, where it cuts the other way, where because black women have a better, perhaps, I wouldn't say better, that's a loaded term, but they have a different hormone profile than other women of other races of people. They probably have and that's my intuition. It might be incorrect, but they probably have a different hormone profile, and so they probably have better protection of their bones. That we don't automatically assume, well, this health inequality is because of some sort of racism against white people. Probably not, I would assume. And it's also probably not because of some sort of racism by white people that causes harm to themselves. It's also probably not true. I would assume it's just because of the natural biological variation of modern humans. But that, again, that's just a digression. Just bear that in mind. There are biological differences between different groups of people. Sometimes this can fall into the category of race. Sometimes it's more familial, right? Just be aware of that. And this is becoming probably maybe not as big of a deal in the year 2026, but it was certainly more of a thing maybe 10 years ago or 15 years ago, if you were there during the Obama years and the first 4 years of Trump, where you see this real leftist disposition towards assuming everything is a consequence of the white devil doing it to black people, basically, which is not exactly a very easy. It's not a very accurate model and has very minimal predictive value, essentially. Not to mention that, of course, it invites racial animosity towards white people, which is its own, issue. So, if the question gives an old woman who has, I'm going back into this now. Okay. If the question gives an old woman who has femoral fracture plus no mention of osteoporosis in the question, the answer should be activity level before the fracture as the most important predictor of success in rehabilitation of the patient. Weight-bearing exercise during life is protective against osteoporosis later. USMLE loves corticosteroids and Cushing as the cause of osteoporosis. Compression fractures, osteoporosis on USMLE, e.g. the patient with rheumatoid arthritis on steroids who has compression fracture, easily diagnosis of osteoporosis. If you have a low to low normal BMI causing osteoporosis is high yield, 2CK NBMEs have a couple of nonsense questions where they give you a BMI of 19 and 20 in young women, in young woman, but they ask what patient is at increased risk of, and the answer would be osteoporosis. Student says, wait, but isn't low BMI under 18.5? I agree, but it's on NBME. So they kind of just don't care. Metatarsal stress fracture high yield is low BMI, young female runners who have low bone density. USMLE is also known to assess how the low vitamin D in the setting of an intestinal malabsorption, i.e. CF Crohn's disease, as cause of osteoporosis, even though that makes no sense since low vitamin D causes osteomalacia. Okay, well, take that as you will. Serum calcium phosphate, PTH, and ALP are normal in osteoporosis. Treatment is weight-bearing exercises first. NBME has go for a long walk outside daily as correct. Wrong answer would be increased participation in swimming pool-based exercise classes to at least 3 times weekly. Calcium and vitamin D are the first medical pharmacologic treatment. Bisphosphonates can be used after calcium/vitamin D. Teriparatide is an N-terminus PTH analog that stimulates bone development. Denosumab is a rank L monoclonal antibody. which I believe is used to prevent the actual activation of osteoclasts. Because basically what happens is that osteoblasts have this thing called rank L, or this kind of thing. Whatever. There's a rank L interaction between osteoblasts to activate osteoclasts, and the osteoclasts can then go do their work. So denosumab helps prevent that interaction from occurring, which would activate or trigger the osteoclast activity and therefore the breakdown of bone. Let me go look up something. You know what? It might also be. Here's another thought process. I'm going back into the black women question for osteoporosis. It might also be that black women have higher obesity, so they just are less likely to have osteoporosis. That might be the explanation. It says here, black women have lower overall prevalence of osteoporosis primarily due to a higher peak bone mass during youth, more efficient calcium conservation by the kidneys, and a slower rate of bone loss with age. Okay, but why though? This is higher peak bone mass. Black women typically have a denser, stronger skeleton. Okay. Yeah, we're just saying the same thing. These physiological and genetic advantages provide stronger bone structure. Oh. So now that's genetic. Oh, well, why do black women have lower rates of osteoporosis? Oh, it's just genetic. It's, just normal genetic variation in human beings. Oh, okay. What, is this true for the other way around? No, of course not. That's definitely racism against black people. Okay. Black women are 40% less likely than white women to undergo blah, 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 blah. Okay. I would assume it might be a combination of just different physiological differences as a consequence of genetics, hormone profile differences, and maybe because they have higher obesity rates, and so as a consequence they're less likely to have these very low BMI women who are at elevated risk for osteoporosis. That might just be part of it as well. Oh, that's a fun. I just saw this. Sorry, this is funny. Here's a Reddit post in Are Black Men 5 actual biological differences between black and non-black people. Okay, so these are the real biological differences. If there's anything that advantages black people, that's clearly a consequence of biology. But we can never actually apply that to anything that might be implied that they somehow have a disadvantage in other departments of health or physiology or whatever. When it comes to that, that's definitely that's the white man putting him down or something like that. Okay. Okay, man. Okay. What? Okay. I'm just having a little bit of fun, High yield bone tumor points for surgery. I only discuss the ones relevant to surgery shelf. Osteosarcoma, most common primary bone cancer, usually in patients aged 10 to 30. RB mutations, congenital retinoblastoma, are associated with osteosarcoma high yield, i.e., 1-year-old boy has enucleation of the eye for retinoblastoma. What is he at risk of developing later in life? The answer should be osteosarcoma. It can also occur in Paget disease of bone patients, older age. Buzzy findings are Codman triangle and sunburst appearance. Codman triangle is the periosteal reaction with lifting of the periosteum off the bone. Sunburst appearance is the periosteal reaction described on MBME as a spiculated new bone formation. So let's see this picture right here. It shows here, the white arrow is the common triangle. Okay. The white star is the sunburst appearance. NBME writes osteosarcoma description as a pleomorphic neoplastic cells producing a new woven bone as the correct answer choice. Again, this is osteosarcoma. Unicameral bone cyst. Underrated diagnosis for USMLE asked on 2CK exam. Benign bone tumor that looks similar to osteoclastoma, but the age of onset usually birth to age 20 rather than between 20 and 40. Unicameral means one chamber, it is fluid filled. 2CK wants you to know that this image for unicameral bone cyst. What about metastases? Metastases, USMLE loves mets to the vertebrae, particularly from the breast, prostate, and lung. The exam will not show the images of spinal cancer mets. but they will give a vignette of either lytic lesions of vertebrae in patient with background of cancer, or it will give neurologic syndrome, i.e. of cauda equina. Diffuse bone in patient with background of cancer equals METS. The above image shows a technetium 99 bone scan of cancer METS. A similar imaging, I should say it's METS with metastases. So above image shows a technetium 99 bone scan of cancer metastases. Similar imaging is on 2CK forms for prostate metastases. So let's see. High yield myopathy / muscular dystrophies for USMLE. Duchenne / Becker muscular dystrophy. X-ray disorder caused by mutation in dystrophin DMD gene. Mutation results in disruption of alpha / beta dystroglycan, which is required for proper internal cytoskeletal anchoring of the muscle cell to the extracellular matrix. Presents with pseudohypertrophy, where the muscle appears large but are replaced with fibroadipose tissue, connective tissue stromal cells. Duchenne presents in a young boy who implements Gower maneuver to stand up, uses arms to walk off the floor because leg muscles are weak. Becker presents in adolescence or young adulthood, less severe form of Duchenne's. Duchenne is classically frame shift mutation. Becker is classically not frame shift. And that's why it's not as serious. Frame shift really screws things up, potentially. I'm going to go take another break here and I'll come back to you. Just skip ahead if you're watching replay. Okay, I am back, and let us hopefully wrap up what remains of this chapter. Again, we are on 327. We're wrapping up 327. We're going to go to 328, and we finish up the section on 331. So let us continue forth. Polymyalgia rheumatica, PMR. Usually a patient over 50 with proximal muscle pain and stiffness, no weakness on physical exam, plus creatinine kinase, CK levels are normal. If one or both of these findings is present, the answer is polymyositis, not PMR. Can present with high ESR and low-grade fever. Any autoimmune disease flare can present with low-grade fever. PMR can present with or without temporal giant cell arteritis. Temporal arteritis can present bilaterally on MBME exams. Do steroids first to prevent blindness, followed by biopsy second. Temporal arteritis can cause jaw claudication, pain in the jaw during episodes. In contrast to temporomandibular joint dysfunction, a separate diagnosis, jaw claudication will be precipitated by eating. No specific joint diagnostic test. Diagnosis is made clinically. The treatment for this PMR, polymyalgia rheumatica, would be steroids. NSAIDs are the wrong answer and are not proven to be effective. Go for steroids for PMR. Polymyositis dermatomyositis. Usually a patient over the age of 50 with proximal muscle pain and stiffness. These findings are not unique to PMR, but they can also be found in these conditions of polymyositis and dermatomyositis as well. The USMLE will happily give pain and stiffness in polymyositis vignettes. Key distinction between polymyositis and PMR is that polymyositis will present with 1. Muscle weakness on physical exam, and or 2. Increased serum CK. The muscle weakness must be on physical exam if the patient complains of weakness, but there is no physical exam findings mentioned in the vignette, or physical exam shows a 5 out of 5 strength. There's no weakness. Patients will sometimes mention weakness even though they really just have pain and or stiffness. If polymyositis presents with skin findings, it is called dermatomyositis. That is to say, Gautron's papules, that's Gottron papules, violaceous papules on the knuckles, mechanic's hands, rough surfaced hands, shawl rash, body rash, heliotrope rash, violaceous eyelids, periorbital rash. Don't confuse with malar rash of lupus, systemic lupus erythematous. Patients often positive for anti-Jo1 antibodies. USMLE wants electromyography and nerve conduction studies as first step in management for polymyositis/dermatomyositis. Again, electromyography with nerve conduction studies as first step. This is why they ask on 2CK and BME forms. I have not seen them ask for anti-Jo1 antibodies versus EMG plus NCS as two separate answer choices. Usually the anti-Jo1 antibodies are mentioned in the vignette rather than as a test you need to order. Muscle biopsy is confirmatory, showing the CD8 positive T cells infiltration. The history can describe a CD8 positive T cells and macrophages surrounding the muscle fibers. For whatever reason, dermatomyositis can be a paraneoplastic syndrome of ovarian cancer, shows up on MBME. The treatment would be steroids. So despite all of that talk about how they're different from each other, at the end of the day, you want to do steroids for both the polymyositis/dermatomyositis, but also the polymyalgia rheumatica. And that's the Gautron's pupils for the polymyositis. Yes, okay. What about fibromyalgia? Fibromyalgia, this is a psych condition, not an actual muscle disorder, but is often confused with polymyositis and PMR. Labs will be normal. ESR will not be elevated. Patient will not have a fever. Will describe as a woman in the 20s to 50s with multiple and often symmetric to muscle tenderness points. The treatment is SSRIs. USMLE can write this as an antidepressant therapy, but this confuses the students, but she doesn't have depression though. Right, but SSRIs are still an antidepressant medication. It's just that it can be used for fibromyalgia. Remember, fibromyalgia this is a psych condition, not an actual muscle disorder. It's different from, but is confused with polymyositis and PMR. Again, PMR, we've been saying this a lot, polymyalgia rheumatica. Temporomandibular joint dysfunction. The answer on USMLE, if they give a jaw pain that is precipitated by eating, often confused with jaw claudication seen in temporal arteritis. In the latter, however, the pain is not precipitated by eating. So TMJ dysfunction associated with eating. That's what you hear. TMJ dysfunction, temporomandibular joint dysfunction. That's precipitated by eating, but with temporal arteritis, it's not. Myotonic dystrophy. Autosomal dominant CTG trinucleotide repeat expansion disease. Myotonia is an ability to relax muscles. The answer on USMLE is that the patient cannot relax their grip on doorknob/handshake or cannot let go of a golf club. Sometimes associated with early/frontal balding. Okay. Hypothyroid myopathy. Myopathy can occur in both hypo and hyperthyroidism, yes, but this is especially high yield for hypothyroidism on USMLE. They will often sneak this as an proximal muscle weakness or increased CK in patient who has ongoing fatigue, dyspnea, and menstrual irregularities, etc. What about drug-induced myopathy? Classically seen when statins and fibrates are combined, but both drugs can cause myopathy independently. Mild CK elevations are normal and expected in patients when commencing these agents. Dose does not need to be decreased for mild CK elevations. USMLE wants P450 mediated interaction as a cause of the myopathy when statins and fibrates are combined. Mitochondrial myopathy. Broad term that can refer to numerous mitochondrial diseases. USMLE wants you to know that the patient has a mitochondrial disorder when he or she presents with a hypotonia, ear and eye problems, and lactic acidosis. You want to memorize that tetrad: hypotonia, eye and ear problems, lactic acidosis. Memorize this tetrad as synonymous with mitochondrial disorders. Ragged red fibers can be a buzzy descriptor in mitochondrial myopathy. Questions. Mitochondrial disorders are maternally inherited only. Why? Because you get your mitochondria from your mother. Because the mitochondria are these little organelles that are in the cells. And because the egg cells are when a zygote is created, when the sperm enters and fuses with the egg to create a zygote, which is a new, unique organism, may it be in a human being as a unique human being or in another animal, for example. Regardless, that is a new, unique organism. Zygote is the starting point, but that most of the material of the zygote of that zygote comes from the original egg cell, which comes from the mother, including the organelles like the mitochondria. And you get mitochondria has its own genetic information for replication, and so if you have, which is called mRNA, mitochondrial RNA, and so if you have a mitochondrial disorder, where you're getting it from? Your mother, right? Because she's the one that's giving you the mitochondria. You don't inherit it from your father. Heteroplasmy refers to offspring having varying disease severity based on variation in allocation of disease mitochondrial genes. I talk more about this stuff in my high-yield biochemistry PDF. Inclusion body myositis. The answer, if they tell you a patient is 50 or older, has mouth to ears of progressive muscle weakness, plus biopsy of muscle, shows basophilic rimmed vacuoles, shows up on the new 2CK form. Connective tissue disorders. Here we go. You know, they were assigning stuff for us to study, and they're saying, look into the connective tissue and joint stuff. I'm like, okay. I'm reading this MSK section just at large, but there is a connective tissue section in this MSK area. So, what do we have in terms of time? 141. Okay. Connective tissue disorders. Marfan. Autosomal dominant, chromosome 15, FBN1/2. Codes for fibrillin, which is a glycoprotein that forms a sheath around elastin. Tall, lanky body habitus with flat feet, chest wall abnormalities, i.e. pectus excavatum or carinatum, flat feet, pes planus, scoliosis, mitral valve prolapse, mid-systolic click. Increased risk for aortic dissection, can retrograde, propagate toward the aortic root, causing root dilation and aortic regurgitation, decrescendo diastolic murmur, is not associated with barosacular/saccular aneurysm, unlike Ehlers-Danlos and ADPKD. Defect in the collagen 3 synthesis can be written as defect in synthesis of the fibrillar collagen. This can be confusing because fibrillin is So it's not associated with barrier/saccular aneurysm, unlike Ehlers-Danlos. Okay, and adult polycystic kidney disease. Okay, so Marfan syndrome is an issue of fibrillin, which is an FBN1/2 gene in chromosome 15. It's autosomal dominant. Again, the person is tall, flat-footed, scoliotic, mitral valve prolapse. They have this sort of aortic dissection issue potentially as an issue that could pop up, and they can have aortic regurgitation with this decrescendo diastolic murmur. However, for Marfan syndrome, you do not have Ehlers-Danlos, you do not have a barrier/saccular aneurysm risk, unlike Ehlers-Danlos syndrome, which we'll go into in a bit, or adult polycystic kidney disease. I think that's what we're talking about. They say ADPKD8. I was referring to the polycystic kidney disease. Remember, Marfan fibrillin, okay? Marfan fibrillin. But what about Ehlers-Danlos syndrome? Defect in the collagen 3 synthesis can be written as defect in synthesis of fibrillar collagen. So this is a collagen issue for Ehlers-Danlos, collagen for Ehlers-Danlos. This can be confusing with fibrillin, is completely unrelated and refers to Marfan syndrome. It is just coincidental that fibrillar collagen means type 3 collagen. The wrong answer would be abnormal synthesis of extracellular glycoprotein, which refers to the fibrillin for Marfan syndrome, which is mentioned above as glycoprotein that forms a sheath around the elastin. Presents as easy bruising plus hyperextensible skin. So Ehlers-Danlos, remember, it's collagen 3 synthesis issue. For Marfan's, it's a glycoprotein issue with fibrillin specifically. There's some overlap in presentation, but it's not the same thing. Osteogenesis imperfecta. Collagen 1 defect that results in recurrent fractures in a child. Important differential diagnosis are child abuse and osteopetrosis. Blue sclera, too buzzy and often not mentioned because, again, it would be too easy. Conductive hearing loss due to defective ossicles, middle ear bones. Many different types of osteogenesis imperfecta, some resulting in miscarriage. Yeah, some of them are pretty nasty. Harder vignette can mention a child with multiple fractures where the mom has a history of recurrent miscarriage. Mixed connective tissue disease. Answer on USMLE if they give you a patient who has a anti-U1 ribonucleoprotein, U1 RNP antibodies. Patient presents as having a combined feature / symptoms from the 3 different disorders, LPS to lupus to polymyositis to scleroderma. So let me read that again. So from 3 different disorders, LPS, lupus, polymyositis, scleroderma. Those are things you have to be worrying about in this context. Yeah, patient presents as having combined features and symptoms of the 3 different disorders, lupus, polymyositis, scleroderma, for mixed connective tissue disease. Again, that's related to a anti-U1 ribonucleoprotein antibodies. Let me take a brief break. High-yield neck MSK masses for surgery. Thyroglossal duct cyst. The answer in USMLE if they say there's a painless midline neck lump in a child that moves upward with swallowing or protrusion of the tongue. This buzzy description is seen for maybe only about half of the questions. Again, that's a painless midline neck lump in a child that moves upward when swallowing with protrusion of the tongue. Okay. Can also be described as a painless mass inferior to the hyoid bone that demonstrates uptake with a technetium 99 scan. USMLE wants endoderm of foramen cecum as the embryology. Again, that's endoderm of foramen cecum for thyroglossal duct cyst. Very roundabout way of talking about it, but okay. Endoderm of foramen cecum. Yeah. Hopefully I remember that if it comes up. Sternocleidomastoid injury, SCM injury. They answer on USMLE if they say nodular mass in the lateral neck in an infant who had been born via forceps delivery, risk factor for damage to the muscle. Okay, so he had forceps delivery, he might have an SCM injury. Branchial cleft cyst. They answer in USMLE if they give idiopathic lateral neck mass that may or may not have been an opening to the skin, branchial cleft cyst. Lingual thyroid. Neonates or infants answer on the hypothyroidism plus midline neck lump located high in the neck. They say nothing about protrusion of the tongue or uptake into the mass. Of course, this is a thyroglossal duct cyst instead in that case. However, this has some overlap in presentation, but it's different. It doesn't have those other features that you associate with the thyroglossal duct cyst, but it does have, sometimes cause dysphagia, trouble swallowing, dysphonia, voice changes, or dyspnea, difficulty breathing. But again, it has some overlap in presentation of thyroglossal duct cyst, but because it's a lingual thyroid, it will have hypothyroidism. And it will not have some of those other features like the technetium uptake, where it says it will not have the protrusion of the tongue, and it will not have the uptake into the mass of course, this is thyroglossal duct, yeah. Highest yield MSK farm for internal medicine. So this is the highest yield MSK farm for internal medicine. So, get set, get ready. Pull out your notepad, Alendronate. Bisphosphonate inhibits osteoclast. This mechanism of action is high yield. Used for osteoporosis after calcium/vitamin D. I've seen pimodronate, not alendronate, show up on the 2CK forms for treatment of hypercalcemia after normal saline is given. Students get fanatical about bisphosphonates causing osteonecrosis of the jaw. The yieldness of this adverse effect is basically non-existent on MBME exams, though. USMLE wants you to know that bisphosphonates cause pill-induced esophagitis. This is very high yield for 2CK forms. Potassium supplements also cause esophagitis. Teriparatide, N-terminus of the PTH analog, this is parathyroid hormone analog, that can induce bone formation, even though parathyroid hormone causes bone resorption. Basically what happens is that both PTH and this analog teriparatide act in this whole system, this sort of system related to the bones and the absorption of different things. But overall, PTH is largely osteoclastic in nature, while overall teriparatide is overall osteoblastic in nature. They both want to, in theory, increase calcium concentrations, but teriparatide leans osteoblastic, while the PTH, which is the OG hormone the body creates itself, leans osteoclastic. So it's interesting, they have opposite effects in a certain sense, even though one's an analog of the other. This agent stimulates osteoblast-mediated bone formation more than it induces rank L-mediated activation of osteoclasts. And bear in mind, how are osteoclasts activated? By who? Osteoblasts. So basically, teriparatide, like the PTH, I believe, you could look this up if you want more better detail, or more accurate detail, perhaps. They both activate osteoblasts, and these osteoblasts can both activate osteoclasts, but for the PTH itself, the osteoclastic effect is more notable and stronger and more prominent, and so more bone reabsorption is happening, versus teriparatide, which is this analog, which has more of an osteoblastic effect. Of course, both of them activate osteoclasts to some degree or another, and that's always mediated by an osteoblast activation by this hormone in both cases. It's just that one leans more to one effect versus the other. Can be used for severe advanced osteoporosis. And bear in mind, the real purpose of PTH is to increase calcium concentration. It's not to break down bone. it breaks down bone in as much as that breaking down bone helps increase calcium availability, right? PTH and, of course, the analog teriparatide, they also increase the production of available active 125 hydroxy vitamin D, which means they both encourage more calcium absorption as well. Again, that makes sense if you are trying to, for example, trying to increase calcium availability in the blood. But if you're just, but it also would, in theory, as it is the case certainly for teriparatide, it can also encourage bone formation. Again, more so in the teriparatide's case, the opposite is, it leans the opposite direction, of course, for the PTH because of the osteoclastic effects that exist also simultaneously. Denosumab, monoclonal antibody against RANKL, can be, so if I were you, if you really wanted to look more into that stuff, because it's its own complex process of how those things interact with each other, how they interact with the phosphate absorption, calcium absorption, either in the gut or how it's removed how it's removed or expelled in the urinary system, how bone is being promoted or it's being broken down, all that kind of stuff. Denosumab, monoclonal antibody against RANKL, can be used for severe advanced osteoporosis. Basically, it's preventing the osteoclast from being activated by the osteoblast. Baclofen agonizes GABA B, used for spasticity, classically in multiple sclerosis, but I've seen it on NBME question where it's used for random spasticity in an older dude. Students frequently remember that GABA B for this drug, but they often say the antagonist. When I probe them further, so remember, it's an agonist, not an antagonist at GABA B. It's it's going to agonize it. Cyclobenzaprine, muscle relaxant used for spasms, structurally similar to TCAs, helps modulate pain sensation at brain stem. Benstropine, muscarinic cholinergic receptor antagonist, used to treat acute dystonia due to antipsychotics. If the patient starts having an antipsychotic and then gets stiff neck, ocular gyre crisis, abnormal eye movements, or muscle rigidity without fever, the answer should be benstropine is what's causing it. Oh, I'm sorry. Benstropine used to treat acute dystonia due to antipsychotics. So basically, if you have a stiff neck, so if you're taking an antipsychotic and then you get, as a consequence of taking the antipsychotic, you get stiff neck, ocular gyre crisis, and muscle rigidity without fever, then you should go take a benstropine. Take benstropine in that context. Diphenhydramine and chlorpheniramine. Okay. In this case, first generation histamine 1, H1 antagonist. Diphenhydramine is quite possibly the highest yield drug on USMLE, used to treat acute dystonia similar to benstropine as well as motion sickness. H1 blockers can treat allergies in theory, but they have nasty anticholinergic or antimuscarinic side effects. The anticholinergic side effects are interestingly a good thing. However, when we want to treat acute dystonia, site questions will either list benstropine or diphenhydramine or chlorpheniramine as the answer, but not both at the same time. So here we go. Let's continue. For whatever reason, anticholinergic effects treat motion sickness. Scopolamine is an anticholinergic used to treat, I wouldn't say for whatever reason. There is a reason, actually. And if you really want to, you can go look into it. Off the top of my head, I don't recall exactly how it works, but I do recall it being a thing that has a particular mechanism described. Scopolamine is an anticholinergic used to treat motion sickness classically, but I've seen NBME ask diphenhydramine straight up for this as well. The nasty anticholinergic side effects are, once again, a good thing if the aim of the treatment is motion sickness. First generation H1 blockers can cause a cognitive dysfunction, delirium, as well as worsening of dementia and drowsiness. Therefore, avoid an elderly and locomotive machine operators if possible. Yeah, it's not good. In many cases. Again, unless you're trying to deal with motion sickness. First gen H1 blockers can also cause anti-alpha-1 adrenergic effects, orthostatic hypotension. I talked about this at the farm-related stuff in a lot more detail in my free farm modules on the website. And finally, dantrolene blocks ranitidine calcium channel, Treatment for neuroleptic malignant syndrome, NMS, and malignant hyperthermia, MH, if the patient gets muscle rigidity and fever following commencement of antipsychotic or following administration of succinylcholine during surgery, the answer should be dantrolene. Bromocriptine for NMS is low yield and rarely seen on NBME. NBME will sometimes give you a vignette of an NMS, neuroleptic malignant syndrome, or a malignant hyperthermia, and then answer for treatment would be decreases sarcoplasmic calcium release, i.e. via the dantrolene. Now, in NMS and MH, the ranitidine channel, which allows calcium to move from the sarcoplasmic reticulum into the cytosol, gets stuck open, so the amount of calcium moves into the cytoplasm. So high amounts of calcium starts entering the cytoplasm. The cell then needs to use a lot of ATP to pump the calcium back into the sarcoplasmic reticulum. This generates heat, which causes a fever. Dantrolene closes this channel. Okay. And that concludes our section for MSK. So if this video is how long? It is just short of 2 hours. So if you like that video, subscribe, like, leave a positive comment, that kind of stuff if you want to. Hopefully this was of good utility to you if you watched it. Anyways, have a great rest of your day. Thank you and goodbye.